Thank you very much to the CoStar planning team for inviting me to present today at the conference. It's really a pleasure to be here. I also just want to recognize Dr. Enola Proctor and thank her for training hundreds of implementation scientists in the field. Because of Enola's building capacity efforts, it's possible for someone like me to have had a career dedicated to implementation science, and for that I'm very grateful. So thank you, Enola. I was invited to speak today to all of you on stakeholder engagement in implementation science, which is actually something very that I'm very passionate about. So I'm really glad to be able to be here. I am an employee of both the VA healthcare system in Bedford, Massachusetts, as well as Brown University, where I now direct the Implementation Science Core in the Department of Psychiatry and Human Behavior. I wanted to start with this quote because I think it's just so powerful and meaningful. That Don Berwick first said at a 1998 meeting of the Picker Institute in Austria, where he said, we can't have, there should be nothing about me without me, when he was talking about patient-centered care. And so this phrase, nothing about me without me, became part of this paper in 2001 that he did with Tom Del Banco and colleagues. And what I really think has happened in the past 20 years is that when we think about what's important in terms of our efforts for planning our interventions and our implementation studies, is that the me has expanded. Patients are still critical, super important stakeholders to involve, and that's always number one. But we've also gone to think about the other stakeholders that are critical to be part of our efforts, such as hospital and clinic leadership, frontline providers, front desk staff, medical clinic staff, family members, people who work in hospital settings but may not actually have a clinical role. So there are lots of people to think about when we think about stakeholders. And so I would like us to think about this quote, nothing about me without me, in terms of who those other me's are that we need to be thinking about. And just so that we're on the same page, when I think of a stakeholder, I use this definition: any individual, group, or organization that can affect or can be affected by another individual, group, or organization. So it's important to recognize that stakeholders, yes, can be individuals, but they can also be groups. And I'd like us to expand our thinking in that way. And another important aspect of stakeholders is this quote, that the more salient a stakeholder is and the more central they are in a network, the stronger the influence. And this is really helping us think about the fact that not all influences are good and are in our favor. And so when we think about different types of networks that exist in any setting in which we hope to implement an evidence-based intervention, there are going to be people who support us, and then there are going to be people who are not aligned with our efforts for a variety of reasons. And in this hypothetical social network map that you see here that was published in Science in 2012 in a seminal paper on network interventions by Tom Valente, the people who are denoted by the orange circles are those who said, yes, I'm going to adopt this evidence-based practice, this evidence-based intervention. But the people in the white circles said, no, I'm not going to. And you can see that in some cases, the white circles and the orange circles interact quite regularly. And so they're exerting influences on each other. And so some of these orange circles will be champions, provider champions, perhaps clinic champions of the efforts that we are trying to implement. And some of these white circles are going to be opinion leaders who are not interested in what we're doing, and they're going to make those views known. So ideally, prior to any implementation effort, we want to understand the full range of stakeholders who are out there and the different views that they have. And so this is what this talk is going to be about, how we can do that and how we can integrate those views from the beginning into our implementation efforts. And when I think about stakeholder examples, I really think about the different groups that are involved in the projects that we run. So we have steering committees and advisory boards. We have hospital and clinic leadership who need to buy into our efforts. We have consumer and family engagement groups. We have provider groups. We have the people who are participating in our research, the research participants. There are our colleagues, both those who are local as well as those who are national, who may be aligned with us, but may also be competing with us. And then in the case of the VA work that we do, we have elected officials and we have the media who can also serve as stakeholders who are quite challenging sometimes in the ways that they interact with us. When I first became involved in wanting to know more about stakeholders, I wanted to reach out beyond the implementation science literature and really see what other fields were thinking about this. And so I ended up in the management science and strategic management and operational management literature, which has been really fascinating to learn more about. And clearly, as indicated by this date of 1984, people in this world have been thinking about stakeholders for a while. And Freeman, who was at the University of Virginia, came up with this stakeholder theory. And really has these important questions for us to be thinking about prior to any launch of any effort. And I really encourage my research groups that I'm involved with and the mentees that I have to before even writing a proposal or starting a project, that we need to ask these questions of our, as a team and come up with some answers. So these questions are: who are our current and potential stakeholders? What are their interests and rights? How does each stakeholder affect us, and how do we affect each stakeholder? And what assumptions do we make about each important stakeholder? So these are great questions to start with as you are thinking about, the different roles that different stakeholders might play in any implementation effort that you're going to have. And then once you identify those stakeholders, you can do a mapping exercise where you categorize them into these 4 different groups. And these different types of stakeholder groups were identified by Savage and colleagues also from the management science world, and really thinking about whether you have supportive stakeholders. I mean, those are the ones that we want. Those are the ones that we often put on our advisory boards and steering committees. These are the ones who are most likely going to be cooperative with us and not at all competitive. But there might be marginal stakeholders, those who are both low in cooperation and low in competitive threat. And it would be fine if they stayed there, but we need to keep our eye on them and think about what their interests are and how to make sure that they don't rise to the non-supportive stakeholder level, which is the next category of people who we already know have low cooperative potential, but seriously high competitive threat. And this might be a union, for example. I'm not against unions. I'm just pointing out that if you are trying to launch an implementation effort and trying to get an evidence-based practice into routine care, it might involve a nurse needing to do a different part of the daily routine that may seem to go against what the union thinks is that scope of work. And so we need to think about how to make sure we are involving those unions from the beginning so that we can make sure that we don't exacerbate any of that competitive threat. And then there's the mixed blessing group, where there's high cooperative potential but also high competitive threat. So colleagues of ours who might be doing the same work, who might see, isn't it great that more people are doing what we're doing, but then may also feel like we're getting into their space. So how can we involve those groups from the beginning? So I really encourage people to do a stakeholder mapping where you do this 2x2 table and you identify who your marginal stakeholders are, your non-supportive stakeholders, your supportive stakeholders, your mixed blessing stakeholders. And then from there, we can think about strategies, implementation strategies that we can use to involve those different stakeholders in our work. And we can go with the ERIC implementation strategies that you've heard about, but we can also go with what has been talked about in the management literature, which is, trying to think about how to keep encouraging those who are already supportive to be involved in our efforts. For those who are non-supportive, thinking more defensively, how can we bring them in to make them feel that they are part of the process so that they feel that they have a role in what we are doing. For those who are mixed blessing stakeholders, where they both have high potential cooperation and high potential threat, We want them to feel like we are all making decisions together about our efforts. And those who are marginal, where we feel like they probably won't have any detrimental effect on our implementation efforts, but we just need to make sure that we're monitoring them. And so we need to think of a specific role for them in this process. I would like to point out this really helpful toolkit that the VA has developed, available on this website, as a nice involvement strategy for involving patients or consumers in your activities. This SERVE toolkit, which stands for Strengthening Excellence in Research through Veteran Engagement, really helps researchers think about 5 different ways in which patients can be involved in a research project. So it could be anything from helping have patients involved from the planning stage, where they are more of an advisor to what we're doing, or they could become consultants on the project. They can even become co-investigators if you want to have that kind of role, and maybe you have a long history of working together. But I feel like this toolkit is useful for either the VA population or the civilian population. I feel that there's a lot of useful activities in here, and a lot of this work was created by colleagues of mine at the Bedford VA. As well as colleagues across the country. So now I want to provide you with a case study of how you can engage stakeholders from the beginning, learn their perspectives, potential barriers to implementation, and build those into the implementation process. I've had the great pleasure of working with a team at the University of Pittsburgh Medical Center, who many of you may know, Carol Greco in psychiatry and Ajay Wasan in anesthesiology and pain. Dr. Greco developed something called HEAL measures. HEAL stands for Healing Encounters and Attitude List. They are 6 different sets of survey measures that really measure the context in which people are seeking healthcare treatment. And through a series of studies funded by the NIH and PCORI, really developed these valid, reliable measures that have been shown to not just be associated with, but predict how patients experience pain, as well as other types of measures that are assessed through the PROMIS measures, the Patient-Reported Outcome Measurement Information System measures such as physical functioning. So this project was a specific D&I project funded by PCORI, which means that there are no research staff involved in the actual implementation. So this was really fun and exciting to be part of. We've actually published the formative evaluation work that I'm going to be talking about in the psychiatry research issue that was published in January of 2020. And I really encourage people to look at this, because this entire issue is a terrific primer on implementation science. There are about 12 articles and really helpful. So despite the fact that this is psychiatry research, it's very useful for all types of sciences. So formative evaluation is described as a rigorous process of assessment to identify potential and actual influences on the progress and effectiveness of implementation efforts that was coined by Cheryl Stetler and colleagues. It enables researchers to explicitly study the complexity of implementation and suggest ways to answer questions about context, adaptations, and responses to change. And there are 4 stages of formative evaluation that you can use throughout an implementation process. So we started this project with the PCORI funded D&I project with the developmental pre-implementation. But then we also launched into more implementation focused and progress focused efforts as well. The paper in psychiatry research explicitly focuses on the developmental formative evaluation. So the HEAL survey items, the healing encounters and attitudes list items, have 6 different categories. I'm just going to touch on the treatment expectancy one because that's just a theme that's going to run through the rest of this talk. But there are 6 questions that Carol and colleagues identified to help people understand more about treatment expectancy. So as part of this battery of questions, there are these 6 items that people respond to, such as I am confident in this treatment will be successful, I feel good about this treatment, I expect good outcomes from this treatment is right for me, I value this treatment. In any implementation project, as you've heard, you really need a theory or framework or model to really guide what you're doing. And in this case, we chose the theory of diffusion of innovation. I really liked this theory for this reason, because I felt that when we're trying to think about why people will adopt any type of innovation, they may not realize it, but they're thinking about, well, what's the relative advantage of this compared to what I normally do? So if I'm in this clinic, they're asking a lot of questions already that are tied to the electronic health record around the PROMIS measures, the patient-reported outcome measurement information system measures, on physical function, on depression screening, and on pain. Why should we adopt the HEAL measures on treatment expectancy, for example, in addition to that? So that's one thing to think about. And then we are also interested, is it compatible with the clinic's perceived needs, values, and norms to be asking about treatment expectancies? Is it too complex, or is it of low complexity? We want things to be low complexity because they are more likely to be adopted. So we need to understand what are some of the challenges that are related to complexity before. And then there are other elements like, can we test this out on a limited basis? Can people see the observable benefits from this? And is there a potential for adaptation for local circumstances? So really felt that this theory was the right theory to guide this work. Laura Damschroeder has said that there's no such thing as a perfect theory or model or framework, but there are better fitting ones. And so that's what you're really trying to go for, is what is the better fitting one in this case? And I just wanted to give you a snapshot of some of the data that we got. So we did formative evaluation interviews, 38 of them, as a developmental formative evaluation in a pre-implementation stage with patients, providers, and medical staff. And we went through each of the sets of questions of HEAL. So this is just a snapshot of the treatment expectancy. And so in this case, we have this table of patient views and provider views mapped to the different elements of the diffusion of innovation theory, such as high relative advantage or low. And we did this throughout the notes from these interviews that we took. So in this case, this patient says, I think it is important, referring to the treatment expectancy questions. The provider needs to understand that my time is important. When I go to the pain center, I don't expect to leave pain-free, just it rather needs to be tolerable or manageable. My doctor feels the opioid problem is due to people wanting no pain rather than managing it. I do the treatment to avoid having spinal surgery. So that's like such an important thing for someone to recognize, right? For a provider to realize that this is what this patient is, the expectations are probably off here. And another provider also thought that there was some relative advantage. But then there were some examples of having low relative advantage, where patients thought that these questions were similar to ones that they already answered in the clinic, like related to depression screening, for example, or they're just worded differently. Or the provider felt like the questions were very repetitive and were being seen as trick questions. So those were ideas that we took forward to address. So this was our process for moving from, on the left, implementation barriers. So those are our formative evaluation interviews. And then we identified where the barriers were located within the theory of diffusion of innovation. So those were the first two steps that I just showed you. Then we took what we learned from these interviews and then mapped that barrier to a specific implementation strategy from the ERIC literature. So those 73 different strategies. And then we, following Proctor guidelines, really wanted to make sure that we named the strategy, defined it, and specified it, because oftentimes we say we're going to use an implementation strategy, but it's not at all specific and concrete and not able to be used. So from there, you can, once you've been specifying it, you can create a specific tool or action to be implemented. And therefore people can replicate this, because we are trying to create generalizable knowledge. And so as you've heard, there are 9 different categories of implementation strategies, and we really focused on this bucket of training and educating our stakeholders, our providers, our patients, and our front desk staff, because we need them to be implementing this. We don't have any research assistants or staff in the clinic. This is something that they're really taking on and implementing in the clinic themselves. So I'm just going to show you some examples of how we enacted implementation strategies. In terms of developing and distributing educational materials, we did this for patients, for providers, and front desk staff. This was just an example of what we did for a patient. We gave them a flyer, the front desk staff gave it out to patients to really help them understand why treatment expectations are important. In this case, we said Jack was starting treatment for his chronic pain. While completing his pre-appointment questionnaires, he noticed his rating, his confidence in treatment was low. He told his pain management specialist that he didn't have high hopes for his treatment. And then, so this showed how Jack could really use these treatment expectancy questions to talk to his doctor and gain more confidence in this treatment. And together, Jack and the pain management specialist discussed the treatment plan, why the treatment could help his condition, and how they could work together. And so then provided some frequently asked questions about the treatment expectancy questions, so that these came right from the formative evaluation, thinking like, why are these questions repetitive? Will my doctor actually talk to me about these? Will these discussions affect my treatment? So really trying to assure patients that this was all in their benefit. For providers, we did additional things other than just distributing educational material. We had different educational meetings that we conducted. Dr. Wasan had a full clinic retreat where he invited everyone from the clinic across the 7 clinics to come for half a day, where he presented the formative evaluation information, showed the different things that we would be doing to implement strategies to make this better for them. He also hosted a journal club to talk about different types of alternative treatments to opioids that could be used for treating patients with pain. We also did a lot of conducting of ongoing trainings. We hired a motivational interviewing coach to run lunch and learn sessions. Everyone always responds to food. And so at the 7 different clinics, we would have multiple lunch and learn sessions. We took notes on what barriers and facilitators were coming up at these meetings. And we also decided that it might be really helpful to develop some videos as an educational tool. And so we created videos under 2 minutes. This is Dr. Wasan starring in the videos. You can see this is our HEAL YouTube channel. We have 3 subscribers, me, Carol Greco, and Ajay Wasan. And there are 6 videos. And so for 6 weeks, we sent 1 video per week to each clinic and asked them to watch it. And so there's one on treatment expectancies, but there's also one on patient-provider connections and positive outlook, which are other aspects of the HEAL measures. And then we created this red cap survey where we asked people watching the videos to indicate what clinic they were at, how many people were watching the video together, and did this video help them understand, in this case, the HEAL treatment expectancy, and did they find it useful to include HEAL treatment expectancy in conversations with patients. We had an incentive going that for the clinic that watched the most videos, we provided them with coffee and donuts. And then we also asked them to let us know what they thought about the videos. And I want to show you one where this is about how to have that conversation, which is really important.
Oh, hi, Nate. Good to see you.
How are you?
Good, good. Thanks for doing all those questions. It's really helpful. We take a look at them and see how folks are doing. It really helps us track over time. So I was looking at it, and one thing I noticed is it doesn't seem like you're very optimistic that these treatments are going to help you that much. So you want to tell me about that a little bit?
Yeah, I mean, I try to stay in good spirits, but, ever since the accident, there's always going to be pain there. I just don't know if it's ever going to improve.
Yeah, so you're right. It's not going to all go away, but we do think it can get significantly better, maybe about 30 to 3% to 50% better over the next several months. And so that's a bit of a glass half full, half empty scenario, in which when people feel at least 30% better, usually they feel definitely better. They feel like they can do more things, and they're at least have some satisfaction with that. But again, it doesn't make it all go away.
Okay.
Oh,
thank you.
Well, good. So last time I prescribed some medication for you, baclofen, to help with some of the muscle pain and the pain shooting down your leg. How did that go?
It went pretty good. There were some days where it would be kind of come and go, even though I was taking the medicine pretty regularly. But I think overall, if I keep doing it, it might get a little bit better.
Okay, great.
So we had a lot of positive feedback. About over 70% of the staff at the sites, at the 7 clinics, watched these videos each week, and gave us some helpful feedback on them. So these were just a range of different educational implementation strategies that we were using. But I think what was important is that we involved our stakeholders from the beginning. Especially, there were many who really didn't think that the questions were going to be helpful in their clinical work with patients. So it was important to learn what they were thinking and how we could adapt what we were going to do as a result of that. So we had a whole range of educational strategies to involve a lot of different people in our efforts. And formative evaluation is really a key part of that implementation effort, and gives you a chance in the beginning, when you take that stakeholder theory and you ask all yourself, who are the people that I really need to know about and learn from? That's when you develop your formative evaluation plan to make sure that you're involving those stakeholders from the beginning. And coming up with a range of implementation strategies is really helpful, as you've heard from other speakers. And we don't know at this point how any of these implementation strategies have improved pain treatment, referrals, or whether they've helped to actually manage patients' pain. That's the last step of our project, and so we'll be working on that soon. So that's really the big question: is has this worked? So that's stay tuned. That's part 2 of this talk. But thank you very much for involving me, and really happy to be part of this. Thank you.